Which of the following condition does not have a risk of cervical deformity greater than the general population? A. Neurofibromatosis. B. Larsen syndrome. C. Dystrophic dysplasia. D. Achondroplasia. E. Down syndrome. And the answer is D. Achondroplasia. Agree, everyone? Now let's get to know about its condition and its relationship regarding the cervical deformity. Neurofibromatosis and cervical deformity. Severe cervical kyphosis in the setting of NF1 neurofibromatosis type 1 is a rare manifestation of the disease in the pediatric population. Dystrophic and immature bone complicate the placement of hardware necessary for surgical correction of alignment. Neurofibromatosis patient presented within second decades of life, whereby the symptoms include neurological deficit, a neck mass, osteolysis of vertebral bodies with kyphosis of more than 90 degrees. It is among the common radiological features. Larsen syndrome and cervical deformity. It is a rare genetic disorder. It can be inherited as either both autosomal dominant or recessive. Patient manifests with either A. Atlantoaxial instability, subaxial cervical kyphosis, in poor neuric grade with or without any history of trivial trauma. B. Asymptomatic in terms of compressive myelopathy with C. Facial dysmorphism, a dish face, and D. forelimb deformity. The triad of odontoid hypoplasia, small bullet-shaped vertebral bodies, and typical faces of dish face is diagnostic of Larsen syndrome. Other comorbidities include osteochondrodysplasia, multiple joint dislocation, and craniofacial anomalies. Progressive cervical kyphosis and craniovertebral junction instability are two most crucial underlying etiologies for spastic quadriparesis. The natural cause of the disease is unpredictable. Next, regarding dystrophic dysplasia and cervical deformity. Dystrophic dysplasia, previously defined as atypical achondroplasia, is a rare genetic condition. It results from mutation localized at the distal long arm of chromosome 5. Diagnosis is possible before birth using a sonograms and DNA testing. Clinical features include short stature with short limbs, hip joint dislocation, unstable knee joint, and club feet. The thumb usually is wide, hypermobile with radial deviation, referred to as hitchhiker thumb. The nasal bridge is narrow with broad nostrils and cleft palate. Scoliosis constitutes the most common spinal deformity together with altered sagittal balance. Cervical kyphosis is less common but may cause severe neurological complications. This picture illustrates the hand of the newborn with dystrophic dysplasia showing brachydactyly, short fingers, and hitchhiker thumb. Okay, everyone. Our answer for this question is achondroplasia and cervical deformity. Nope, there is no association. The reason for our earlier answer is achondroplasia is associated with frequent stenosis of the foramen magnum in infancy as well as lower cervical stenosis. However, it is not associated with an actual deformity of the cervical spine. Lastly, regarding the Down syndrome and cervical deformity. Atlantoaxial instability (AAI) affects 10 to 20% of individuals with Down syndrome. Atlantoaxial instability denotes increased mobility of C2 in relation to C1. The condition is mostly asymptomatic and diagnosed on lateral radiograph by the presence of an abnormally large anterior atlanto-odontoid distance (AAOD). The upper limit of a normal AAOD anterior atlanto-odontoid distance is 4 mm in patients who are younger than 15 years and 3 mm in older patients. The anterior space between the atlas and the axis normally opens in flexion and closes in extension, which is why the AAOD anterior atlanto-odontoid distance is greater when the neck is radiographed in flexion than it is neutral or extension position. This figure shows the drawing of a normal atlantoaxial joint showing the base of the skull, the upper 3 cervical vertebrae, and the measurement of AAOD, anterior atlanto-odontoid distance, and PAOD, posterior atlanto-odontoid distance. The danger of AAI, atlantoaxial instability, is that it becomes symptomatic in 1 to 2% of individuals with Down syndrome when the displaced odontoid impedes the spinal cord. Thank you. With regards to painful arch syndrome, which of the following statement is true? A. Tenderness is generalized. B. Typically, there is severe pain on initiating abduction. C. The cause is a tear of the supraspinatus tendon. D. If untreated, a frozen shoulder often results. E. Calcification in the region of supraspinatus tendon is not seen on X-ray radiograph. And the answer is D. If untreated, a frozen shoulder often results. Now let's revise a bit regarding painful arch syndrome. Painful arch syndrome, also known as the shoulder impingement. The clinical syndrome is patient presented with pain in the shoulder and upper arm, usually during mid-range glenohumeral abduction, around 60 to 120 degrees of motion. The space between the upper humerus and acromion is compromised. The tendon of rotator cuff is ripped between the greater tuberosity and acromion. Pathogenesis of painful arch syndrome can be divided into 1. Primary impingement, 2. Secondary impingement, 3. Subcoracoid impingement, and 4. Internal impingement. In 1. Primary impingement, it can be further divided into A. Intrinsic impingement and B. Extrinsic impingement. For A. Intrinsic impingement, there is an increased volume of contents of supraspinatus outlet, the structure passing beneath the coracoacromial arch will enlarge and abuts against the arch. There will be thickening of the rotator cuff, calcium deposition in the cuff, and subacromial bursitis occur. This figure illustrates the shoulder impingement caused by shoulder instability. In external impingement, the rotator cuff tendons are compressed by the acromyon process. In internal impingement, the structure within the glenohumeral joint themselves are impinged. Both are primarily caused by joint instability. B. For extrinsic impingement, there is decreased space in supraspinatus outlet, subacromial spurring, acromial fracture, or pathological acromial osteophytes of undersurface of acromial joint, exostosis of the greater tuberosity, and type 3 acromyon based on Biglini and Morrison classification, which are the causes of extrinsic impingement. The X-ray illustrates a pathological acromial. Number 2. Secondary impingement. There would be normal supraspinatus outlet, glenohumeral instability causing anterior translation of the humeral head, the rotator cuff contacts against the coracoacromial arch. For number 3, coracoid subcoracoid impingement. There would be a contact of rotator cuff and coracoid process. The idiopathic cause is due to prominent coracoid. Iatrogenic cause, it can be attributed to coracoid osteotomy procedure. For shoulder instability, we call it trilithite procedure. We can confirm a subcoracoid impingement by doing a Gabon subcoracoid impingement test. How to do it? The arm is flexed at 90 degree, adducted 10 to 20 degree, and the lesser tuberosity will contact with coracoid, and if there is pain elicited, it means impingement. Number 4. Internal impingement. The rotator cuff contacts with the posterior superior glenoid usually occur in throwing motion, whereby abducted, extended, and externally rotated shoulder. It is commonly to occur in a throwers who have lost the internal rotation. The center of rotation of the humeral head move upward and the rotator cuff contacts with the bicep tendon attachment. Lastly, regarding the developmental stages of impingement syndrome. For stage 1, there will be an edema and hemorrhage, usually occur in the age less than 25 years old. Usually, we treat with conservative management, that is physiotherapy and NSAIDs. The differential diagnosis include subluxation and acromioclavicular joint arthritis. In stage 2, there would be fibrosis and tendinitis, usually occur in the age of 25 to 40 years old. There would be a recurrent pain in activity. The management is by bursectomy or division of coracoacromial ligament. The differential diagnosis include frozen shoulder and calcium deposits. In stage 3, it usually occurs in patients more than 40 years old. There is progressive disability. The management is anterior acromyoplasty, rotator cuff repair. The differential diagnosis include cervical radiculitis, neoplasm. Thank you. Which of the following is not a cause of a swan neck deformity? A. Mallet deformity. B. Flexor tendon synovitis. C. Volar plate rupture. D. Central slip rupture. E. Lateral band subluxation. And the answer is D. Central slip rupture. Okay, everyone? Now let's get to know a bit regarding a swan neck deformity. Swan neck deformity, it is characterized by PIP hyperextension, proximal interphalangeal joint hyperextension, and flexion of the distal interphalangeal joint. There is also reciprocal flexion noted of the metacarpophalangeal joint. This is a result of an imbalance of the extensor mechanism of the digit. The imbalance could be due to a significant laceration or stretching of the extrinsic tendon forces on the distal phalanx or from tightness and pulling of the extensor mechanism, both intrinsic and extrinsic, at the proximal interphalangeal joint. This figure shows a characteristic of swan neck deformity where the proximal interphalangeal joint PIPJ in hyperextension and the distal interphalangeal joint DIPJ in flexion. Boutonniere deformity and mallet finger are also shown in the illustration. Etiology of the swan neck deformity. The swan neck deformity develops from either loss of extension mechanism at the distal phalanx or tightening or overpull of the extensor mechanism on the proximal phalanx. Initially, swan neck deformity can develop from loss of the extensor tendon at the terminal tendon at the distal phalanx, which over time can progress to the characteristic deformity. Injury to the terminal tendon can result from the following: a traumatic laceration to the extensor mechanism, a close avulsion from a direct blow on the distal phalanx on the extended digit, attrition by weakening from chronic inflammation at the distal interphalangeal joint DIPJ along with the extensor tendon subluxation due to rheumatoid arthritis or any other inflammatory process. This illustrates the swan neck deformity where the DIPJ, distal interphalangeal joint flex, and the PIPJ, proximal interphalangeal joint in hyperextension. Hyperextension of the proximal interphalangeal joint can be due to tightness of the intrinsic muscles and increased pull at the central slip. This could be secondary to rheumatoid arthritis, spasticity from traumatic brain injury or stroke, and intrinsic tightness alone. Laxity of the volar plate is also a cause of swan neck deformity and the hyperextension seen at the proximal interphalangeal joint PIPJ. This picture illustrates the causes of swan neck deformity caused by the volar proximal interphalangeal joint PIPJ synovitis due to attenuation of volar plate, attenuation of transverse retinacular ligament, dorsal translation of conjoint lateral band, flexor tenosynovitis, rupture of the flexor digitorum superficialis. The reason for our answer is D, the central slip rupture, because based on this illustration, when there is disruption of the central slip, it will lead to a boutonniere deformity. Okay, thank you.